right, so in the last video, we left off talking about blood pressure regulation, and we talked about this at the level of cardiac output. So if y'all remember, the cardiac output idea is actually in our blood pressure equation. So remember, the equation for blood pressure was cardiac output times heart rate, right? Not heart rate, just kidding. Times total peripheral resistance. So total peripheral resistance. And so if you increase cardiac output or resistance, that's going to increase your blood pressure. And we said that the way you control your blood pressure, and with that flow chart we drew together, there's three ways we can do this, right? We can control this using your heart, your blood vessels, or your kidneys. Now, your heart and your blood vessels are part of this sort of short-term sort of regulation of blood pressure, because these are under the influence of hormones and your nervous system, which are pretty rapidly acting, okay? Now, the long-term regulation of blood pressure regulation would be at the level of the kidneys. So we call that renal regulation. And the reason why the kidneys are involved with long-term blood pressure regulation is they regulate blood pressure by regulating blood volume. And they do this by altering how quickly you make urine, right? So for instance, if your blood pressure is high, you can actually make urine to help decrease your blood volume to decrease your blood pressure. But that takes time. So that's why it's sort of like a long-term regulation of blood pressure is your kidneys. Short-term, think your heart, blood vessels, because it's under the control of hormones and your nervous system, okay? So what this slide here is showing you guys is sort of how this works quickly. So with any kind of feedback mechanism or regulatory mechanism in the body, we're going to need a receptor of some sort. Because if you guys remember from AMP1, we said that receptors are the things that pick up change, right? They sense the change. And so the receptors for blood pressure in our body are found in these little areas called the carotid sinus. And the carotid sinus is right at the split of the common carotid arteries into the internal and external carotids. So it's just kind of superior on your neck, just inferior to the angle of your mandible, like right around here. You'd find your carotid bodies, or sinus rather. And then within that carotid sinus, you find what are called baroreceptors. So baroreceptors measure pressure, right? So if pressure is higher in the vessel, then these baroreceptors are going to sense that change. They're going to pick up that information, right? Now they're going to send that information back to the brain through the vagus nerve and glossopharyngeal nerve. And then the blood pressure regulatory centers of your brain, which you find in the brainstem, specifically the medulla oblongata, those are going to basically decide what to do with that information. So if your baroreceptors pick up information about stretch, that stretch information is sent to your brain, and then your brain decides the appropriate output. Now the appropriate output for high blood pressure would be to slow your heart rate down and vasodilate. So that kind of makes sense, right? Because if we go back to our blood pressure equation, we said that blood pressure is cardiac output times total peripheral resistance. So if you slow down your heart rate, what's that going to do to cardiac output? It's going to decrease it. Very good. So slower heart rate decreases cardiac output. And then what about if you vasodilate? What is that going to do to your resistance of your blood vessels? Vasodilate, resistance of blood vessels decreases as well. Good. So this is also going to decrease resistance. So what we find then, you guys, is that if you decrease heart rate and you have vasodilation, then your blood pressure is going to decrease. And that makes sense because the original stimulus or change was high blood pressure. And this is sensed by these carotid sinuses you find in both carotid arteries on either side. Okay, it's right at the juncture. This is also why you can do a carotid massage, by the way. So have you guys ever heard of that before? Like if someone has hypertension or high blood pressure, and you're concerned about like their blood pressure being too high. Well, if you bear down on the carotid sinus here and kind of massage that and force pressure on it artificially, you're kind of tricking your brain into thinking your blood pressure is even higher than it should be, right? Or than what it is, because you're artificially pushing on those, right? Now, when you push on those, then what happens is it's going to cause your heart rate to slow down and cause your blood vessels to vasodilate, which is kind of interesting. That's also one of those pressure points that they kind of teach you, like in like self-defense classes and stuff. Because if you hit someone in the neck hard enough there, basically what the brain receives is, oh, blood pressure got high all of a sudden. But it wasn't like your blood pressure actually got high. It's just because someone hit you in the neck. Right? So And then your brain goes, oh, my blood pressure is high. So then your brain tells your heart rate to slow down and your blood vessels to vasodilate, and guess what? They pass out. So you guys ever seen that before, like in those videos, like someone gets hit in the neck, also they just hit the floor. You know, that's basically like tricking your brain into thinking your blood pressure is high. So it's kind of fun. So it's kind of funny. And so then your blood pressure decreases. And now the opposite's true down here too, guys. If you have less stretch in these baroreceptors in the carotid sinus, then your brain says, oh, your blood pressure is too low. So then what happens is that's going to cause your heart rate to increase and your blood vessels to vasoconstrict, which both increase blood pressure. And so these two opposing negative feedback loops help keep you at a homeostatic range, you know, whatever that might be, kind of just like a normal blood pressure there in the middle somewhere, okay? So what this next slide shows you guys are the renal mechanisms, which are the renal mechanisms short-term or long-term? Long-term, right, because it takes longer for your kidneys to respond to blood pressure than like, you know, your heart rate and blood vessel diameter, because those are under the control of hormones in your nervous system, which are pretty fast, right? Now with your kidneys and the long-term regulation of blood pressure, we have two mechanisms here. We have the direct renal mechanism and the indirect renal mechanism. The direct renal mechanism is actually pretty cool. This is because your kidneys are little filters, right? They filter your blood. But they only filter based on pressure. So for instance, like to make urine requires blood pressure because basically blood is forced through a membrane due to its pressure, right? So here's the interesting thing, is that if your blood pressure is low, already low, okay, and you don't have pressure present to form urine, then you stop losing water from your bloodstream because you're not making urine anymore, right? You're not filtering that blood. So you maintain your blood volume. And if you add this with like drinking water and other sources of water in your body, like from metabolism, what you find then is that by decreasing the rate of urine formation, you actually increase blood volume. And if you increase blood volume, you increase blood pressure. Now the relationship of blood volume to blood pressure, you guys, was kind of a weird indirect one. But if y'all remember, it has to do something with cardiac output. Because if y'all remember, cardiac output was stroke volume times heart rate. And then stroke volume was EDV minus ESV. And so what we find then, you guys, was that venous return, and we talked about this on Tuesday, but venous return was the return of blood back to your heart, which is essentially EDV. And so venous return is influenced by blood volume, right? So if you have a higher blood volume, you're going to have more venous return, which means you're going to increase your end diastolic volume, which is going to increase your blood pressure by increasing your cardiac output. And that's kind of what's implied here. Like, I know that's not in this arrow here. Like, it all of a sudden it jumps from blood volume to blood pressure. Like, what? What's the relationship there, right? Now, just remember that as a rule. If your blood volume is higher, your blood pressure is going to be higher, okay? But the way that works is through this pathway, right? If you increase blood volume, you increase venous return, which increases filling in your ventricle, which increases stroke volume, which increases cardiac output, and therefore blood pressure, okay? So that is the direct renal mechanism. And it's actually the opposite too, like if your blood pressure is high. Let's think about this, you guys. What if your blood pressure were really high? Your kidneys would actually filter more blood, right? And by filtering more blood, they're going to make more urine. And if you're making more urine, you're basically losing water from your bloodstream, which means your blood volume is going to go down. And if your blood volume decreases, what happens to blood pressure? It decreases. Good. So that's kind of the cool thing about your kidneys, you guys, with this direct renal mechanism. It is basically just due to the anatomy of the kidneys. This is not like regulated in any way. It's just based off what the kidneys normally do. They just automatically adjust your blood pressure. Because if your blood pressure is high, they're going to make more urine. If it's low, they'll make less urine. In either circumstance, it's going to reverse the change. So it's negative feedback, right? So, okay, cool. Now, the indirect renal mechanism actually involves a series of hormones. And I don't know if we talked about this back in the endocrine system, but your kidney does release several hormones. I know we talked about one already, was EPO. Remember that one? So remember, your kidneys can release erythropoietin if your blood oxygen levels are low. But your kidneys also release a hormone called renin when your blood pressure is too low. So if you guys look here, if your blood pressure is low, we see that renin is released by your kidneys. This is because of an increase in sympathetic nervous system activity. So renin is a hormone and it's an enzyme, which is kind of weird. So when your kidneys release this hormone/enzyme into the bloodstream, it floats around your blood, and then what renin does is it converts a hormone called angiotensinogen into angiotensin 1. Now, angiotensinogen actually comes from your liver, so your liver makes angiotensinogen. But if you guys remember, if it ends with ogen, we say that this is an inactive thing, right? Like pepsinogen was an inactive form of pepsin. So we're saying that renin basically converts angiotensinogen into angiotensin 1. This happens in the blood, right? Because it's actually a hormone. So angiotensin 1, though, is still technically inactive. Like this is a hormone, but it doesn't really do anything until it's converted to angiotensin 2 by an enzyme called ACE. And ACE is called angiotensin converting enzyme. Now you find ACE in your lungs, your kidneys, your brain, and your liver. And so there's lots of different places that angiotensin converting enzyme exists. But essentially what happens is that once you form angiotensin 1 and this hormone circulating through your bloodstream, it's eventually going to be converted to angiotensin 2 by the enzymes that are in those blood vessels. Okay? Now angiotensin 2 is the active one. And this is the one that does exert effects on your body. Now, angiotensin 2, though, has 4 major effects. Okay? The first one is that it makes you thirsty, which is kind of interesting. Like if you feel thirsty, it could be because angiotensin 2 is high in your bloodstream. It's kind of cool. And the way it makes you thirsty is that there's actually receptors for angiotensin 2 in the hypothalamus of your brain, like in the thirst centers of your brain. And that kind of makes sense, right? Because if your blood pressure is low, why would you want to get thirsty? To increase volume, right? But if you're thirsty, what are you going to do? You're going to seek out water. You're going to drink some water or whatever. You know what I mean? Not everyone drinks water when they're thirsty. Sometimes people just drink soda or whatever. It's mostly water. You know what I mean? So they drink out, they seek out some sort of fluid. They drink that fluid, water containing, and then that water gets absorbed into their body. What happens to their blood volume when you absorb more water? It goes up, right? If you increase blood volume, what happens to blood pressure? It goes up. Good, we just talked about that. Awesome. So angiotensin 2 makes you thirsty. Now, it's not the only thing that makes you thirsty. You got to keep that in mind. But we'll come back to that when we talk about electrolyte imbalances in a future chapter. Okay? So the next thing angiotensin 2 does is it also causes vasoconstriction. And so by vasoconstricting your blood vessels, that also increases your blood pressure because that increases resistance. So if you guys remember, blood pressure is cardiac output times total peripheral resistance. And if you vasoconstrict, not vasodilate, but if you vasoconstrict, it increases resistance, which increases blood pressure. Okay? And so that makes sense. Angiotensin 2 is a potent vasoconstrictor, which increases blood pressure. And angiotensin 2 stimulates the release of 2 additional hormones. So angiotensin 2 acts on your posterior pituitary to stimulate the release of antidiuretic hormone, or ADH. Now, ADH has 2 names. Remember, it's antidiuretic hormone, but it's also called vasopressin because ADH does 2 things. It causes your kidneys to retain more water. That way, it decreases your urine output and increases your blood volume, which would increase blood pressure. That's what we're seeing here. So antidiuretic hormone prevents diuresis, right, or water loss. So antidiuretic hormone. So it prevents water loss by causing your kidneys to reabsorb more water. So you decrease urine output, but that increases blood volume and therefore blood pressure. But what's not up here too, you guys, remember though, is that antidiuretic hormone is also called vasopressin. So ADH is also a vasoconstrictor. So there should be another line here going this way, because ADH also causes vasoconstriction, and if you increase resistance, then you increase blood pressure. Okay? So this one does 2 things. And then angiotensin 2 also stimulates the release of aldosterone from your adrenal cortex. Okay? So if you guys remember, aldosterone is one of those mineralocorticoids we talked about. And what aldosterone does is it causes your kidneys to retain sodium and secrete potassium. Now, what happens when you retain sodium in your body is that water follows that sodium because water is attracted to sodium through osmosis. So if you keep holding on to salt in your body instead of losing salt into urine, you're also going to retain more water. And if you retain more water, you're going to increase blood volume, which increases blood pressure. Okay, So this is actually a pretty important cascade, by the way. Like this comes up a lot, and I think it'll come back later this semester, but it also will come up again when you guys take pathophysiology and in your future nursing classes. So this is pretty important to memorize. And it's also one of those pathways that's inhibited by certain blood pressure medications, right? Like you guys heard of ACE inhibitors before, right? So an ACE inhibitor would block this enzyme, right? So what do you guys think would be the effect of giving someone a drug that blocked this enzyme? What would happen in their body? What's that? Yeah, it would lower their blood pressure, absolutely. Because it would lower their blood pressure because you're preventing the mechanisms that act to raise blood pressure, right? Because if you block this enzyme, do you get angiotensin 2? No. But is angiotensin 1 in its active form? No, exactly. So if you block ACE and you're not getting the formation of angiotensin 2, you're not going to get those effects that act to raise blood pressure, right? Now, that's not to say that blood pressure is only influenced by these four things. However, these four things are pretty strong, right? So if you blocked ACE enzymes in someone's body, then that would prevent their blood pressure from getting higher, which is actually kind of a good thing, right? So that's kind of cool. And what you'd find then is that they're going to end up peeing a lot more because you're preventing the release of antidiuretic hormone. So if you prevent the thing that prevents diuresis, then you get water loss, right? You'll find that their blood vessels will be more vasodilated. They're less likely to be thirsty, which means they're less likely to drink water. So their blood volume should go down, right? So it kind of makes sense in terms of blood pressure regulation. Cool. So you guys have any questions about this one? You feel good on this one? Okay, cool. All right, guys. So this next slide talks about other mechanisms that act to raise blood pressure. And this is pretty similar to the flow chart that we worked on together in the last class. But if you remember, mean arterial pressure or blood pressure is influenced by two main things. That's cardiac output and peripheral resistance. But remember, there's three things that influence peripheral resistance. That was blood vessel length, blood viscosity, and the diameter of blood vessels. Now, of these three things that influence resistance, which one changes the fastest? Vessel diameter. Very good. And that one's under the influence of hormones and your nervous system. And we'll talk about the hormones that affect vessel diameter here in a minute. But we've already talked about two just in the last slide. Because if you guys remember, angiotensin 2 and ADH were both vasoconstrictors. So they're going to decrease the diameter of blood vessels, which increases resistance and increases blood pressure. Okay. Now we also said that viscosity plays a role with resistance too. So if you have if you're dehydrated or have higher hematocrit, like more red blood cells in your bloodstream, then your blood's going to be more viscous, therefore more resistant to flow, and therefore you're going to have a higher blood pressure as a result. Now this mostly plays a role in individuals who maybe have cancers of blood cells, where they're going to have more blood cells than normal because of that cancer. Things like polycythemia vera, which is a cancer of the myeloid stem cell line in your bone marrow. And so they have way more red blood cells than normal. Like your hematocrit's going to be something like 60% instead of 45, So their blood's more viscous, and therefore their blood pressure can be higher, right? Now, blood vessel length relates to body size. So you'd find then that if someone's obese and their bodies are larger, that their blood vessels are going to be longer too, because when you grow that adipose, let's say if you had an extra foot of adipose on your abdomen, that means there's a whole extra foot, at least, of blood vessels going that direction too. Now that extra length of vessels, because there's more body there, increases resistance. So what does that tell us about obesity and blood pressure? Yep, they kind of go hand in hand, right? If you have more body, therefore longer vessels, your blood pressure will be higher. And those can go hand in hand. Now the thing about this flow chart, you guys, is that it makes a lot of assumptions about how blood pressure is regulated. Right? For the exam, you want to know these rules. However, just because you have longer blood vessels doesn't mean you're absolutely going to have higher blood pressure, because there are other factors at play. You know what I mean? Other things can compensate for long vessels. Sure, what if you had long vessels? You think, oh man, I got long vessels. My blood pressure is going to be high. Oh no. Well, you can also have vasodilation, which could counteract that, right? or you could also do something like change your cardiac output, which could counteract that. So there are other regulatory mechanisms at play. Usually it's not just one thing that's causing high blood pressure. It's a mixture of a lot of different factors. Okay? That's sort of on a whole organism level. But for the exam, you just want to know these rules, right? Like if I said something like, okay, someone with longer vessels because they're obese, what would be the effect on blood pressure? You would say blood pressure would be higher, right? Just because we just want to learn the simple rules first. But when you start talking about whole organisms where there's lots of factors at play, it's a little bit more difficult to make these predictions. But that requires more data, which is more advanced than what we need to go over. So, anyways, over here, you guys, we see the cardiac output side, right? So cardiac output is stroke volume and heart rate. So increasing either increases cardiac output, which would increase blood pressure. We know that heart rate is under the influence of your sympathetic nervous system, and that's under the influence of your brain. And we said that that heart rate is modulatable, or sort of modified by things like your baroreceptors and your carotid arteries. Because if you guys remember, if your blood pressure is too low and your baroreceptors stop sending stretch information to your brain, well, then your brain tells your heart to speed up. So what we find then is that the activation of these vasomotor centers in your brainstem can tell your heart rate to speed up, which increases cardiac output and therefore blood pressure. Now we also find that stroke volume plays a role here too, because stroke volume is part of cardiac output. And stroke volume was dependent on venous return. We said that venous return was dependent on blood volume, and blood volume was regulated by the kidneys. So if your kidneys help you retain more sodium and more water, then your blood volume is going to be greater, and your venous return will be greater, which makes your stroke volume greater, and therefore your cardiac output larger, and so your blood pressure is larger. That's the kind of pathway going back here. So that kind of makes sense there too, guys. Awesome. Now, what can also play a role with venous return is the activity of your respiratory pump and your skeletal muscle pump. And that would be mostly like during exercise, right? Like if you're exercising and you're breathing more heavily, like blood's going to get drawn up to your thoracic cage faster. And if you're squeezing on muscles, blood's going to get squeezed up towards your heart faster too. So that's going to increase venous return, which again would increase blood pressure through that pathway. So for the exam, what you want to know then are these kinds of rules, right? Now what's really cool about this though is that the exact opposite applies for the other way. Like for this whole entire chart, you could just flip all of these factors and have the factors that decrease blood pressure, right? So what would those be? Well, a decrease in viscosity, a decrease in vessel length, an increase in vessel diameter. All of that would decrease blood pressure, right? That's kind of the beauty of this, is that it's just one or the other. So if you learn it one way, you automatically know the other way, right? So, but you want to have these rules down pretty well, you guys. And this is important moving forward, because once we talk about diseases later, like in pathophysiology, all of this comes back again, because we'll talk about, well, what happens to blood pressure when you have, blood cancers, or what happens to blood pressure when you have brain injury and your blood vessels all of a sudden just dilate, and you go into shock. So that's why it's important to know. Do you guys have any questions on this slide? You guys feel good? Okay, cool. So what we're going to move on to next, you guys, is talking about tissue perfusion. So perfusion just refers to blood flow through a tissue, right? Now, we can make some pretty good guesses about whether tissues would need more or less perfusion, because that's going to be dependent on their metabolism. And so what's really cool here is that usually perfusion matches metabolism perfectly, right? So if you have a certain amount of metabolism, you're going to have just the right amount of perfusion to match that. No more, no less, okay? So where this would come into play would be like, let's say if you're just at rest and you're not using your skeletal muscles, you don't need to have a lot of blood flow through your skeletal muscles if they're just chilling, right? So then what happens then is you can decrease blood flow through your muscles at rest. But during exercise, you'd want to increase perfusion. This is done through your nervous system and auto-regulatory mechanisms. So typically the rate of flow is precisely the right amount to match the function of that tissue. But this is dependent on metabolic factors, which we'll talk about in a little bit. And so, but what this column shows you guys is basically cardiac outputs. So remember we said that normal resting cardiac output was like about your blood volume. So this one says 5.8 liters, right, in a minute. So your heart can pump out 5.8 liters in a minute at rest. But during exercise, your cardiac output can shoot up to like 17.5 liters in a minute. And so remember we said that cardiac reserve was the difference between these two numbers. And now if the total column of cardiac output increases, do you guys think that all the tissues proportionally get even more blood flow? Like during exercise, do you think your brain would need to get more blood flow? Or during exercise, do you think that your digestive organs would need to get even more blood flow? No, exactly. Like there's certain organs that actually need more blood flow disproportionately during exercise. And it makes sense because they're involved with exercise, right? So for instance, as you guys can see here, at rest, your skeletal muscles get 1.2 liters of that 5.8, right? During exercise, your skeletal muscles get 12.5 liters of the 17.5. So most of that additional blood flow is actually going to your muscles. In fact, there's 10 times more blood going to your muscles during exercise in this example, right? Now, there are other organs whose blood flow actually decreases during exercise, and that's because of what your sympathetic nervous system does to blood flow. And so an example of this would be like your digestive organs. Do you guys see this during rest? Your abdominal organs can get 1.4 liters of blood flow in a minute. During exercise, they're down to 600, right? They're less than half of their original blood flow at rest. And that kind of makes sense because you don't need to send blood flow to your digestive organs if you're exercising, right? And then your kidneys also get less. That also makes sense though too. But let's think about this from a standpoint of blood pressure regulation. If your kidneys regulate blood pressure by creating urine, would you want to send more blood flow to your kidneys while you're exercising? It wouldn't make sense, right? But let's think about this why. Like what do you guys think would happen if you sent more blood to your kidneys while you're exercising? Well, you'd make more urine, right? And if you're making more urine, what would happen to your blood volume? It would go down. And then what would happen to your blood pressure? It would go down. You don't want that, right? You want to keep your blood pressure up during exercise. So during exercise, you actually decrease blood flow to your kidneys in order to maintain blood pressure during exercise. You also don't need to be like making urine while you're exercising. And like, could you imagine like, you're playing basketball or something, you're like, hold on guys, time out, I gotta go pee. Everyone's calling time out every 2 seconds because you have to pee so much. You know what I mean? Like our sports would be very different if our bodies were structured differently. You know what I mean? Every 20 seconds a timeout. So what this slide shows you guys is a really interesting association between blood flow and the cross-sectional area of blood vessels of your body. So if you guys look here, there's two different graphs. This graph shows the total area of blood vessels, and this graph shows the velocity of blood flow. And what we see on the x-axis over here then are the blood vessels of your body, like your aorta, your arteries, your arterioles, your capillaries, venules, veins, vena cava. So we're kind of going full circle, right? Because this end would be attached to this end with the heart in the middle. So at the artery side, the aorta is our largest artery. But if you guys look here, it accounts for very little of the total area of all of our blood vessels. Even though it's our largest artery, there's not a lot of aorta with respect to all of the blood vessels of your body, right? But then what's weird though is that as you get more and more branches, and it kind of makes sense though, like when the aorta branches into other arteries, and other arteries branch into arterioles, and arterioles branch into capillaries. What you find then is that the most cross-sectional area of blood vessels in your body is at the level of your capillary beds. But that makes sense because that's where the nutrients are exchanged, right? So you want to have the most vessel surface area where there's nutrients and waste being exchanged. So your capillaries have the most cross-sectional area of any vessel in your body. But remember, capillaries are also the microscopic vessels. So we're saying that most of the blood vessels in your body, you can't even see. They're microscopic at the level of the tissue, right? The ones we can see account for a very small percentage of all the blood vessels in your body, which is kind of fascinating to me, right? Like, I think that's interesting. Like, we spent all this time, memorizing the names of arteries and stuff in anatomy, but those ones that we're even naming are, far less than the ones that are there. We just can't see the ones that are there because the ones that are mostly there are microscopic. Now, what's also kind of cool too, you guys, if you go down here, this shows the velocity of blood flow, and it turns out that blood flows the slowest through capillaries. But that also makes sense. So how would that make sense, though? You guys tell me. What do you think? Like, why would it make sense that that blood would flow the slowest through capillaries? There's less pressure there. That's a good thought. Now it ends up that's not where the lowest pressure is, but that's a good hypothesis. That could be it. That's actually probably part of it. But let's think about this like kind of functionally. How would it make sense to have slower blood flow through the capillaries? Yeah, that's where the magic's happening, right? You're right. That's where like absorption's happening, filtration's happening. Like you wouldn't want to like run through the part where like you actually need to deliver the nutrients. You know what I mean? That would be like your UPS driver, like flooring it through your neighborhood and like trying to throw packages out on the way. You know what I mean? Like they're not going to get to where they need to go. It's like, what the hell? Like he threw my Amazon Prime package like 5 doors down because he's going 80 miles an hour through my neighborhood. You know what I mean? So no, what you want then, you want your UPS driver to go fast, and then once they get to your neighborhood, then they can slow down and have time to deliver the things they need to deliver and pick up the things they need to pick up, right? And then once they get out of the neighborhood, then they can speed up again. Cool, and it makes sense. If that's where the exchange happens, you want the slowest blood flow there because you need time for exchange to occur. Okay, awesome. Good job, you guys. So with respect to perfusion, it's actually regulated at the level of the tissue itself. And this is actually, I think, for me, one of the coolest things about blood flow regulation is that you don't even need your nervous system to modulate where blood flows throughout your body. Your tissues do it themselves. So here's the cool thing is that tissues can kind of like recruit their own blood flow. So for instance, like if they're very metabolically active, a tissue can basically like bring more blood to itself. Or if a tissue is not so metabolically active, it can say, hey, I'm good, I don't need as much blood flow. And it can prevent as much blood flow from getting there. And so this works through what's called the autoregulation or autoregulatory mechanisms of blood flow. Okay. Now, basically, it's an automatic adjustment, and there's it's relative to the varying requirements of that tissue. So we say that if a tissue requires more nutrients, then it's going to increase its blood flow. If it doesn't need as many nutrients, it will decrease its blood flow. And so it's controlled intrinsically by modifying the diameter of the local arterioles. So for instance, if a tissue needs more blood flow, it will cause vasodilation of an arteriole, which means more blood will flow through that capillary bed, and you're going to get more nutrients going through there too. If a tissue doesn't need as many nutrients because it has enough, it can cause constriction of that arteriole, which decreases blood flow through the capillary bed. So then, you don't need as much there. Okay. So organs can basically regulate their own blood flow. And so there's 2 types of autoregulation. We have metabolic and myogenic controls. So the metabolic controls, they are chemical messages. And they're chemical messages that correlate with the metabolism of a tissue. And they actually all make sense because, like, if you guys remember, there's certain things that result from metabolism. Like, if you have a tissue that's very metabolically active, you're going to expect that CO2 levels will be higher because CO2 is a byproduct of metabolism, right? And if you have high CO2 levels, you're going to have higher acidity or lower pH, right? And you're also going to expect there to be low O2, right? So O2 should be low because the tissues are using all that oxygen because they're so metabolically active. You're also going to expect potassium levels to be higher in the tissue because potassium is leaking out of these very metabolically active cells. There are also other chemicals that are released by metabolically active cells like prostaglandins, adenosine, and nitric oxide. And so these types of hormone local mediators can also stimulate vasodilation. So let's check this out, you guys. So up top, we see the vasodilators. Down below, we see the vasoconstrictors. So the vasodilators are those which cause a larger diameter of the vessels. And if you have a larger vessel diameter, it decreases the resistance, which increases flow. And this one's different than our blood pressure regulation equation. Remember, the equation for flow was big F equals delta P over R, right? So we said that if you decrease resistance, it increases flow. And the way you can decrease resistance is by vasodilating. Because if you vasodilate, there's less resistance along that vessel, so you get greater flow. So when would you want to vasodilate an arteriole going into a tissue? Well, if that tissue needs more nutrients. Because if you vasodilate, you get more flow, which means you get more nutrients. So what are the things that cause vasodilation? Well, the metabolic factors would be like low O2, high CO2, high acidity, and high potassium. But here's the thing, you guys, is all of these build up in very metabolically active tissues, right? So you would have increasingly low levels of O2 the more and more metabolically active that tissue became. You'd have more CO2 and more acidity and more potassium as well. So it would make sense that these would stimulate vasodilation because the tissue needs more nutrients. Okay. Now we also have prostaglandins, adenosine, and nitric oxide. Prostaglandins are released by the cells, that are hypoxic or have low O2. Adenosine is the breakdown of ATP, right? And that kind of makes sense too, because if these tissues are very metabolically active, they're going to break down ATP, and you're going to get a lot of adenosine, which is a metabolite of ATP. And so adenosine also tells our blood vessels, hey, we're very metabolically active. We need more blood flow. So they vasodilate, right? And then nitric oxide is also released by these hypoxic cells. But nitric oxide is it's a gas, but it's a gaseous hormone, and it's a potent vasodilator. Okay. Now, this is something that your body normally makes, and it causes vasodilation. But that's also something you can give to somebody who's having a heart attack, because that also would make sense, right? Like you guys have heard of this, like people who have a history of heart attack carry like nitroglycerin with them, or you can give them nitroglycerin if you suspect they're having a heart attack. So what are you trying to do there? Well, if they're having a heart attack, that means that there's an area of heart muscle that's not getting enough blood flow. So if you give them nitroglycerin, which is then converted to nitric oxide, what does that do to the blood vessels of their heart? Vasodilate. And if they vasodilate, what does that do to nutrient delivery to their heart muscle? It increases nutrient delivery. You got it. So that can help save their heart muscle from becoming necrotic or dying, right? So that kind of makes sense. So you're basically just amplifying what your body normally does. Now, it's also kind of interesting, too, and we'll talk about this going back when we actually talk about the reproductive system later, you guys, but Viagra also acts on the nitric oxide pathway. How would it make sense for Viagra to increase nitric oxide production? Vasodilate. If you vasodilate, what happens? The magic. Yeah, exactly, right now. Bringing blood to the penis. Exactly, right? Good. So then that would cause an erection. Now, here's the interesting thing too, guys. If someone's having a heart attack and they don't have nitroglycerin on them, the next best thing, Viagra. Like if they have Viagra, and you know what I mean, like, well, we'll take it because it's going to cause vasodilation. You know what I mean? So it's kind of fascinating. Kind of interesting. That's an interesting EMS pickup, right? Like, I didn't have any nitro, but I took my Viagra. Like, oh, yeah. Oh well. So, a decrease in sympathetic nervous system activity also causes vasodilation, you guys. And this hormone called atrial natriuretic peptide. So this one's kind of interesting. It's actually a hormone that's released by the atria of your heart. So when your heart has too much stretch, like when the atria are overly stretched, they can release a hormone called ANP, or atrial natriuretic peptide. Now we've talked about this one going back to the endocrine system, because we said that ANP causes your kidneys to not reabsorb as much sodium, so you lose more water, so it decreases blood pressure. But it also acts on your blood vessels because ANP is a vasodilator. It also decreases blood pressure. So here's a weird thing. It's actually a hormone that's released by your heart, and it basically kind of like is trying to protect the heart from too much blood pressure. So it decreases blood pressure by vasodilation. This is kind of cool. So this is also something you would actually look for clinically. Like, let's say if you suspected that someone had like chronic hypertension or high blood pressure, if their ANP levels were high, that would tell you that, because you don't release ANP unless you've suffered with high blood pressure for a long period of time, right? We're saying weeks to months. This wouldn't be like seconds to minutes from your visit to the doctor or whatever. Okay? So that's something you can also look for. Because sometimes patients will be like, no, my blood pressure is fine. It's just because I'm nervous right now. That's why my blood pressure is high. But you can do a lab test. Look at their blood levels of ANP, and if those are elevated, no, they've suffered from hypertension for quite a while, right? So that wouldn't be conditionally active. So, what causes vasoconstriction? vasoconstriction. Well, this one's kind of interesting, you guys, is that there are some metabolic controls like endothelins, but this one is one of the more important ones to talk about here, guys. And so there's this myogenic mechanism for vasoconstriction. And this one actually makes sense in terms of maintaining a normal blood pressure, because remember, blood pressure is due to compressed fluid. The fluid wants to push up on the vessel wall, causing that vessel to stretch. But what if your vessels were very loose, so that whenever you had high blood pressure, it just caused the vessels to stretch out, right? But when they stretch, that's vasodilation. And if you had a lot of vasodilation because of the blood pressure forcing those vessels open, then your blood pressure would fall down. So how do you maintain normal levels of blood pressure? Well, what you do then is that your blood vessels actually will contract against the pressure. That way they can maintain a steady size of the blood vessel. So for instance, if the internal blood pressure is trying to force the vessel out this way, you can have a corresponding and equal and opposite amount of contraction to keep your blood vessel the same diameter. So keep it the same size. If you keep that vessel the same size, you're going to keep your blood pressure the same. But if you didn't have this myogenic mechanism, so there were only arrows pushing out this way, that means that your blood vessels would get squeezed open due to your blood pressure, and then your blood pressure would drop out, right? Which you don't want. You want to maintain normal blood pressure. So in response to blood pressure, your blood vessels contract against it. That way they can maintain their size. And that's the myogenic mechanism, which is pretty cool. So it maintains normal blood pressure levels by maintaining a steady size of the blood vessel. Okay. So we also have neuronal mechanisms of vasoconstriction. That's your sympathetic nervous system, as well as hormonal mechanisms. So some of the vasoconstrictors will be things like angiotensin II, antidiuretic hormone, epinephrine, and norepinephrine. So you definitely want to know this stuff, you guys. Like there's definitely some questions in the test about, which of the following is a vasodilator, or which of the following is a vasoconstrictor, that kind of stuff. And you want to be able to pick from that list and know which is a vasodilator or which is a vasoconstrictor. So definitely memorize this list. Like the way my brain works personally is I have to kind of explain things and I have to know why it makes sense. It's hard for me to just memorize things. That's why I try to explain this for you guys. Say, okay, well, CO2 is a vasodilator because of this. Otherwise you can just make a flashcard too and just memorize it too. Whatever, it works either way. Okay, so for long-term regulation of blood flow, we have this process called angiogenesis. So angio means, did I say blood pressure? I meant blood flow. So long-term regulation of blood flow is angiogenesis. And so angio means blood vessel. Genesis means to create. So angiogenesis is the synthesis or creation of new blood vessels in a tissue. And so this is done because when tissues are chronically hypoxic, bless you, or have low O2 levels, those tissues can release hormones that attract new blood vessels to grow into the tissue. And that would actually make a lot of sense. Like let's say if you're exercising and your skeletal muscles aren't getting enough blood flow, even though your heart rate's fast. Well, what your skeletal muscle tissues can do is release things like vascular endothelial growth factors, which actually attract new blood vessels to grow in the tissue. So you can grow more vessels. But these are the ones that are microscopic. Like you're not going to grow new vessels that you can see usually with the naked eye. Like you're going to grow more arterioles and capillaries and that kind of stuff. But you're not going to grow new branches of the aorta. That's a different level. So angiogenesis is going to be the growth of microscopic vessels, but this would increase blood flow to a chronically hypoxic tissue. Now, this is also important for cancer too, guys, because cancer cells, if they're really vigorous, they also are really good at angiogenesis. Because remember, cancer cells are also very metabolically active, so they can stimulate a lot of angiogenesis, which means they can attract blood vessels to grow towards the cancer, which makes them grow faster. And so, one of the targets for cancer is angiogenesis. Because if you can stop angiogenesis, you can prevent cancer cells from feeding themselves, which means they can actually be eliminated more easily from your body. Okay? And so with the exchange of nutrients at the capillary bed, we say that it involves diffusion. So for instance, O2 and CO2 are actually both hydrophobic. So they're actually both lipid-soluble gases. And because they're lipid-soluble, it means they can participate in what's called simple diffusion, which means these gases can go just across the membranes of your cells, no problem, but they go down the diffusion gradient, right? So O2 can go into a cell from high to low concentration. And CO2 can leave your cells from high to low concentration, right? And it's basically just due to diffusion. And because they're hydrophobic, they can go straight through the plasma membrane, no problem. That's what simple diffusion is. But water-soluble molecules have to pass through clefts or fenestrations, which we talked about back in capillaries. And then larger molecules like proteins usually need to be transported by like vesicular transport, like endocytosis and exocytosis. And an example of endocytosis was penocytosis. If you guys remember, penocytosis is where you have just like gulps of extracellular material into a cell. Okay? So what does this look like? Well, here's our capillary. And so remember, capillaries are made of one cell layer. So you have one cell layer of a simple squamous endothelium here, and then there's an underlying basement membrane. What type of capillary would this be? You guys remember? Fenestrated. Very good. Nice. Because you can see the fenestrations here, the holes, right? If it were continuous, there wouldn't be these extra holes there, right? So what we find then too, guys, is that there are some intercellular clefts as well, which allow for water to pass through. Otherwise, if it's gases, like oxygen can just flow straight through this capillary wall, or CO2 can just flow straight through the capillary wall because they're lipid soluble. Like they don't have to have any special mechanisms. They're small and they can flow right through plasma membranes, no problem. Okay, so what about the other molecules, like water-soluble molecules? Well, those ones would actually need to go through the fenestrations or the intercellular clefts because they're basically like little spaces, little holes in the cells, right? And so if you're talking about movement of water across the capillary, that occurs through fenestrations or intercellular clefts. Now, if it's things like proteins that are larger, they can't fit through these spaces, those would actually go through vesicular transport, which you guys see over here. So this is important to discuss because we said that capillaries are leaky. But remember, they're leaky to water. And this is also important because this is why we have a lymphatic system. Because if our capillaries of our body are typically leaky, we need lymphatic vessels to pick up that excess fluid. So in the next part, you guys, we're actually going to talk about what's something called bulk flow. So bulk flow is the movement of water across the capillary beds of your body. Now, it turns out, you guys, that you lose about 20 liters of water into your tissues every day. But you can reabsorb about 17 liters of that. So what that means, though, is that you have a net loss of about 3 liters of water into your tissues every day. But that's why you have a lymphatic system to pick up that excess fluid, right? And the reason why you lose this water is because of some different forces here. So there's two major forces at play. We have hydrostatic forces and the osmotic forces, okay? Hydrostatic forces are fluid pressure forces, and then osmotic pressures are due to osmosis. Like they're kind of a pulling force because of solutes, okay? But both of these pressures together influence the movement of water. So remember I was saying you can lose 20 liters of water into tissues? Well, some of those forces are going to bring most of that water back. So although you might lose 20 liters due to like hydrostatic force, you can reabsorb 17 of that back into your bloodstream through osmotic forces, okay? But you have a net loss of 3. So we call that net filtration. So your net filtration of fluid is actually positive, and you're going to lose 3 liters of water into your tissues every day. Okay, so what are our forces? Well, the first two we'll talk about. There's 4 major forces here. The first two we'll talk about are the hydrostatic pressures. So hydrostatic pressures are a fluid pressure. And as a fluid pressure, they're kind of like, compressed fluid like in a hose or like in a squirt gun, because it's under compression. So if you have a place for that water to leave to lower pressure, it will squirt out, right? So think about this, you guys. Since we have fenestrations and intercellular clefts in our capillaries, those are like little holes for water to escape. And since we have pressure in our bloodstream, water kind of squirts out of those holes into the tissue, right? So you're going to lose a lot of water through those holes. But that's not a bad thing because you want to replenish your tissue fluids. It's kind of like keeping it fresh, right? It's keeping it clean. And that way it can circulate back through your lymphatic system. Your lymphatic system can clean it up, goes back in your bloodstream, and then your capillaries can kind of squirt that back out into tissue, Okay. Now, there are two hydrostatic pressures, though. We have capillary hydrostatic pressure, which is your blood pressure, right? So if you're talking about blood pressure in the capillary, that's HPC, or capillary hydrostatic pressure, okay? Now, we also have one that's actually much weaker, and it's called interstitial fluid hydrostatic pressure. And this one's usually close to 0. But this one's actually fluid pressure in the tissue. So not in the blood, but fluid that's in the tissue, like extracellular fluid or interstitial fluid in the tissue. If there's some pressure there, it can squeeze some of that fluid back into your bloodstream too. But this is usually close to 0, you guys, because your lymphatic system acts like a drain. So if interstitial fluid hydrostatic pressure builds up, like if pressure builds in a tissue, typically that's the force which squeezes fluid into your lymphatic vessels. So lymphatic vessels kind of keep that fluid pressure low in the tissue because they're going to take up that excess fluid and take it away from the tissue. Okay, but you can increase this pressure, by the way. So the way you would increase interstitial fluid hydrostatic pressure would be like to squeeze on a tissue. And you guys have heard this before, like with like pressure stockings, or what do you call them? Or like like socks for edema. So what happens there, you guys, is like if someone has a lot of swelling in their legs or something, right? What you can do is give them a sock that squeezes on their tissue. Now, by squeezing on the tissue of their leg, what that does is it increases this interstitial fluid hydrostatic pressure because you're basically squeezing on that fluid, increasing pressure. Now, by increasing HPIF, or hydrostatic pressure of the interstitial fluid, what that does is it can force water either into your lymphatic vessels or back into your bloodstream. And so that can help to reverse the edema then, right? That's a whole rationale behind wearing these pressure socks. So we also have two osmotic pressures too, you guys. So these osmotic pressures are a pulling force. So if the hydrostatic pressures are a pushing force because it's fluid pressure, osmotic pressures are a pulling force. So for instance, like let's say if I'm albumin and there's a bunch of water nearby me, I'm going to have a tendency to pull water towards me because it's an osmotic force where water follows the solute. And this example, the solute's albumin. But albumin you find mostly in blood plasma. So we talk about capillary colloid osmotic pressure, or basically pressure in the plasma due to solutes. That's mostly due to albumin. This is actually a pretty strong force. We're saying that in your bloodstream, it ends up attracting water because it has a fluid pressure of about, or not fluid pressure, but osmotic pressure of about 26 millimeters of mercury. Whereas in your capillaries, it can be anywhere between 33 to 17 millimeters of mercury for the hydrostatic pressure. Let's go back. Does it say that there? Yeah, here we go. 35 to 17 for capillary hydrostatic pressure. So these are the two major players, you guys. Capillary hydrostatic pressure and colloid osmotic pressure. But you guys see here that colloid osmotic pressure is actually lower. So like it's not as strong. And so it can't attract all the water back in. But it tries. Like it gets most of it, right? So like it can get 17 liters back into your bloodstream. Now, interstitial fluid osmotic pressure is solutes that are in the tissue that can attract water into the tissue. And this one's also usually pretty low. So if we can add all these forces up, or add them all together, we get something called net filtration pressure. And net filtration pressure just basically tells us where is the water moving, right? So the equation for this basically are the pressures that force water out or filter it minus the pressures that bring water back into the blood or reabsorb it gives us our net filtration pressure. Okay? So out minus in gives us a number. So if out is greater than in, we see that net filtration pressure is positive, which means you have a net water loss into your tissues. If out minus in is negative, that means you have a net water reabsorption, and that means you're actually not losing extra water in your tissues. You're reabsorbing water from tissues. Okay. Now, net fluid flow at the arterial end is positive. So you have a net water loss at the arterial end because your blood pressure is really high at that side of the capillary bed. At the venule end, your net fluid flow is negative. So you have net reabsorption at the venule side because your blood pressure is lower there, and your osmotic pressure is greater, so you can draw some of that water back in, right? But what you find, though, you guys, as a whole, there's actually more water loss at capillaries than reabsorption. So you have net filtration versus reabsorption at your capillaries. So what does this look like? Well, let's check it out, you guys. So this red vessel here is an arterial, and this vessel here is a venule. So which one would have a larger blood pressure? Which side? Yeah, the arterial end. Good. So what's the term for the force for blood pressure? We just talked about earlier. What's our blood pressure force term? Is it a hydrostatic pressure or an osmotic pressure? Hydrostatic pressure. Good. Because remember, the hydrostatic pressures are fluid pressures due to compressed fluid. So what would it be then if it's a hydrostatic pressure? And it's in the capillary. Hydrostatic pressure of the capillary. So hydrostatic pressure of the capillary is in the capillary, and it's because of blood pressure. And where is that going to force water? Our hydrostatic pressure is a pushing or a pulling force? They're a pushing force. Good. So do you guys see that as blood starts to flow through this capillary, water is pushed out? That's because blood pressure is still kind of high on this side. And that's hydrostatic pressure of your capillary. Okay. So do you guys see that on this side of the capillary, there's a whole lot of arrows pushing water out into the tissue. And this is where you would lose 20 liters of water a day. That's a lot of water, right? Now, if you only lost water at this side, your blood would dehydrate before the day was over, right? Because you only have 5 liters of blood in your body, and half of that is water. So that's a whole lot of water. So we're saying, though, you guys, at the venule side, do you guys see that the arrows reverse? They flip in the opposite direction. So at the venule side, where our blood pressure is lower, we get water reabsorbing back into our bloodstream. But this is because your hydrostatic pressure of the capillary is low, and the osmotic pressure of the capillary is higher, which means you're actually reabsorbing water back into your bloodstream. Because the osmotic pressure of a capillary, which is basically albumin, is attracting water back in. And at this side, you can get about 17 liters back in. So you lose 20 at the arterial end, you reabsorb 17 at the venule end, but that's a difference of 3, right? So that extra 3 that is filtered and lost into your tissues, that's picked up by your lymphatic system and then brought back to your bloodstream. But that's important because, I mean, you kind of want that because you want to replenish the fluid that's here and you want to clean it out. So the way that you get fluid into the lymphatic system is you need to have excess fluid to get from the get-go. So by forcing extra fluid into your tissues, it can actually force that fluid into your lymphatic system, and your lymphatic system can clean up that fluid. So this is something you want to normally happen. You want to have net filtration or net water loss in your tissues, but not too much. Because if you had too much water loss in your tissues, that can lead to edema and dehydration of your blood. So you want just the right amount. So what you need is a pretty good balance of these forces. So let's go over those forces again. So remember, we have hydrostatic pressures and osmotic pressures. Remember, hydrostatic pressures are a pushing force, and that's due to compressed fluid. So an example of a hydrostatic pressure for you guys would be like a super soaker, right? It's been a while since I've used one, but I remember those things were pretty awesome, right? So you got a little chamber of water, and you got to pump it up, right? So when you pump up that chamber of water, what it's doing is it's actually increasing pressure in that chamber, and it's actually causing that fluid to kind of get compressed in that chamber, right? Now, compressed fluid has a tendency to want to flow from high pressure to low pressure, and we already talked about that. That's why blood flows from high pressure to low pressure. So what about inside your blood vessels? Well, that compressed fluid, which is your blood pressure, wants to flow from higher to lower pressure. And you find, you guys, that there's lower pressure in the tissue versus in your blood. So the tendency then is that at the level of capillaries, no other vessels, just capillaries, because capillaries are leaky, right? Like arteries and veins don't leak fluid like this. Only capillaries do. So the tendency then is that because of hydrostatic pressure, fluid gets pushed into your tissue because it's a compressed fluid, right? If your heart's pushing on that fluid and it's compressing it, that fluid's going to get pushed across the capillary wall into your tissue. Remember, 20 liters of water a day. But if that were the end of the story, we wouldn't be here right now, right? Because our blood would dehydrate pretty darn quickly. So what we need is an opposing force. So let's imagine this, you guys. Let's say if this is our bloodstream, this is our tissue, and we have a whole lot of solutes on this side and not as many solutes on this side. Well, this would be an example of like albumin, which is a protein, right, in your plasma. Well, albumin is a pulling force, because it's osmotic pressure, because it can pull water back in, because it attracts water due to osmosis. So if you have one force that's pushing water into the tissue and another force that's pulling water back in, that keeps it pretty well balanced, right? But which one's stronger? Do you guys remember? Is it the hydrostatic pressure or the osmotic pressure? Hydrostatic, yeah. And that's exactly why we actually have more water in the tissue, and you can't reabsorb all that water. So you actually end up with some water staying in the tissue rather. And that's why we have a lymphatic system. Okay, good. So let's check out these forces again, you guys. So what this shows are our four major forces at the level of the arterial, right? So here at the arterial end of the capillary, our hydrostatic pressure of the capillary is 35 millimeters of mercury. Our osmotic pressure of the capillary is 26 millimeters of mercury. But because this force is greater than this force, so we're saying that we're going to have a net filtration of water in the tissue. Now, there's two other forces too, guys, but they're usually pretty negligible because hydrostatic pressure of the interstitial fluid is like 0, and osmotic pressure of the interstitial fluid is 1, right? So these do play a role. They're important to consider, but the two major players here, you guys, are hydrostatic pressure of the capillary and osmotic pressure of the capillary, okay? So remember, hydrostatic pressure of the capillary is your blood pressure, and then what's osmotic pressure of the capillary due to? Like, what's the solute that's in your bloodstream here that's causing this osmotic pressure? Albumin. Very good. Nice. So what if you had a disease where you couldn't make albumin anymore, like liver failure, or you're losing albumin in your urine from like membranous nephropathy? What would happen to this OPC if you started to lose albumin? Good. So OPC would go down. And if you had, but would this arrow change though? No, your blood pressure would stay the same, but you would have less osmotic pressure. So what would that mean in terms of fluid movement? You'd have a lot of fluid going to your tissues, right? So what do you guys think happens to people who have too low albumin, like hypoalbuminemia? What happens to their tissues? They get a lot of edema. Very good. Nice. So keep that in mind, you guys, because when we go back, when you guys take pathophysiology, we're going to talk about this. We're going to talk about how liver failure leads to edema. And it's because when the liver is failing and it can't make albumin, then you start to lose extra water in your tissues because now you don't have that osmotic pressure of the capillary. And some forms of renal failure also lead to edema. Because if your kidneys are failing because they're structurally damaged and you're peeing out albumin instead of keeping it in your bloodstream, same thing, it leads to edema. So keep that in mind, you guys. It's important to know. Okay. But this is only at the arterial end, right? So at the venual end, it gets a little different. Because, and check it on the next slide, you guys. So what's the difference between these two? What changed? Do you guys see? Yeah, which pressure lowered? Hydrostatic pressure of the capillary. Remember, this is blood pressure, and that kind of makes sense because as you go across the capillary bed, your blood pressure starts to decline. So if your blood pressure is lower here, but osmotic pressure of the capillary is the same. So which one's greater now? The albumin one, right? Osmotic pressure of the capillary. So what do you guys think happens to water movement at the venual end of the capillary? Do you get net water loss into tissues? Do you get net filtration or net reabsorption? Yeah, you good. You get net reabsorption. Good. So this is what accounts for the 17 liters of water that's reabsorbed. So at the arterial end, you filter 20 liters of water. At the venual end, you reabsorb 17. But the reason why you don't get it all is because your hydrostatic pressure of the capillary is still kind of high there. It's still lower, but it's still, high enough such that you don't reabsorb all the water that was filtered in initially, okay? And so what ends up happening to you guys is that you get a net filtration of 3 liters, which is good though. I mean, you still want to have that happen because you want to recycle the fluid that's in your tissues. Okay, so does that make sense, you guys? So you want to know these 4 forces though. So let's give some examples. If someone had hypertension, which is high blood pressure, which of these forces would increase? Hydrostatic pressure of the capillary. Very good, because that's in the bloodstream, right? So hydrostatic pressure of the capillary would increase. So what do you guys think happens to people with high blood pressure as a result? Think about this. Let's say if this slide showed normal blood pressure, and let's say if this slide showed hypertension, where your blood pressure is higher. What happens to water flow or movement if you have hypertension? Yeah, water goes out. You get more filtration. So what can you guys expect to see then? Maybe if someone has really high blood pressure, edema. Very good. So a high blood pressure can also lead to edema because you're increasing this hydrostatic pressure of the capillary. Very good. So there's another one here, you guys, and we talked about it a little bit, but I wanted to re-mention it, or mention it again rather, is hydrostatic pressure of the interstitial fluid. That's out here in the tissue where due to fluid pressure in the tissues, you can kind of force fluid back into your bloodstream. But it's usually 0 because you have a lymphatic system that picks up the excess pressure. But if you wear pressure stockings or pressure socks, this can increase to something like 3 or 4 millimeters of mercury, and you can force extra fluid into your blood. And that can help aid with the reversal of edema if you're worried about that in your patient. Okay? There's another one too, guys, called OPIF, or osmotic pressure of the interstitial fluid. And this one can change if someone has like an infection, because if you have a lot of bacteria here in the tissue, those can actually attract more water too, because they're kind of like solutes. Or if your blood capillaries were too leaky, you can actually leak solutes out into the tissue, and this OPIF can actually get stronger because maybe if you have albumin in the tissue instead of being in the blood, you can actually get more water being drawn into your tissue as a result. So it's important to know what these 4 forces are, which way they attract or force water, because when they go wrong, you want to know which way is water going to go, right? So if the balance of these forces is askew, for whatever reason, where's the water going to go? And we'll come back to this in pathophysiology too, so make sure you guys have this one down as well, okay? All right, so let's wrap up really quick with circulatory shock. So circulatory shock, you guys, is any condition where the blood vessels are inadequately filled and blood cannot circulate adequately, okay? There's lots of things that can cause shock, but the 3 kind of categories we're going to talk about here are hypovolemic, vascular, and cardiogenic shock. So hypovolemic shock is low blood volume. This would be from like blood loss from a big wound or something, or really severe dehydration. But in either regard, if your blood volume is low, your blood pressure is low, which means you can go into shock, okay? Now, vascular shock is where your blood vessels just vasodilate for some reason. And there's different things that can cause vascular shock, like brain injury or spinal cord injury or nerve injury. Because remember, your sympathetic nervous system is what causes vasoconstriction. So if you have head trauma and you lose your sympathetic nervous system, all of a sudden your blood vessels can vasodilate. And that's what we call neurogenic shock, which falls under vascular shock. Okay? Now, vascular shock is what we also call distributive shock, but we'll come back to this in patho. Now, what can also cause vascular shock is anaphylactic shock and septic shock. Because in both anaphylaxis, which is an allergy, or septic shock, which is infection, they both cause vasodilation from the inflammatory immune reaction. Okay? So you get massive vasodilation, your blood pressure drops out, blood flow drops out as well. Okay? Now with cardiogenic shock, this is due to heart failure or the inability of your heart to adequately pump blood. Right? So if someone is suffering from heart failure, they can go into cardiogenic shock. So what this slide here shows you guys are all the events that help to reverse shock. And I can tell you guys before you even look at this chart, what those would be if shock is low blood volume, low blood pressure and low blood flow. What those would be are all the mechanisms that would act to increase blood pressure and increase blood flow throughout your body. So you don't even need to even read this necessarily because you already know the mechanisms that act to increase blood pressure, right? So let's say if someone's in shock, what would happen to their heart rate if you want to increase their blood pressure? Increase heart rate. Very good. If someone's in shock, what would you want to do to their venous return? Increase venous return. And you can do that by breathing heavily, right? So you go, start taking deep breaths, and you can draw that blood back to the heart faster, right? If someone's in shock, what would you want to do to their blood vessel diameter to increase their blood pressure? Vasoconstrict, exactly, good. So it gets their blood pressure up. I can just tell you guys this now. The way you get better blood flow, and it's almost counterintuitive, is you got to have high blood pressure to have any flow. Because remember, flow is a pressure gradient over resistance. So even though you think, well, okay, well, why would you want to vasoconstrict if that increases resistance? Well, you got to keep your pressure up, right? So you got to maintain our blood pressure to have any flow at all. So in the case of shock, the thing you want to do first is actually vasoconstrict. You can worry about the resistance part later, but you got to maintain blood pressure to have any kind of flow at all, right? You don't want to have no pressure because then flow zero, right? So what you find then is vasoconstriction, which acts to increase blood pressure and increase blood flow. So other things that can happen to you guys, in terms of like the brain, you'll see things like restlessness or anxiety. They can also have coma if their blood pressure is so low that it can't support their consciousness. And they also get thirsty. They get thirsty because their blood pressure is low. If their blood pressure is low, they get angiotensin II being released, which makes them feel thirsty. Right? So it's kind of interesting.